Hi everyone, welcome to this episode of GoggleDocs' latest podcast. This is a breaking news episode, in fact, where we'll be discussing a trial that has just recently been announced. But before we get to that, there's also a bit of a celebration because today we launched our YouTube channel as well. And if you haven't had a look at our first video, please do click on the link that's on the screen, which will take you to our review of the previous year in diabetes, so a review of 2020. But before we get going, let's introduce ourselves to you all again, the GoggleDocs team. So over to you first, Kevin.
Hi everybody, Kevin Fernando here. I'm a GP, specialist interest in diabetes in North Berwick, just near Edinburgh.
I'm Patrick Holmes, a GP in Darlington in the Tees Valley.
And I'm Arpitana, a diabetologist in the West Midlands.
Hi, and I'm Amrit, a GP based in North London with an interest in diabetes and education. So as I mentioned, this is a breaking news episode of our GoggleDocs podcast. So a shorter version, and we're just going to be focusing on one particular trial that was just announced in terms of the results. We had a press release. So this is the ColCORONA trial. Kevin, I'm going to hand over to you to introduce this to us and give us a little bit of context as well to the trial.
Absolutely, this is really fascinating and of course much needed, given the the really tragic complication and mortality rates associated with COVID. But really the top line here is colchicine. Good old-fashioned colchicine appears to reduce complications in outpatient COVID-19. So eminently relevant, generalizable to certainly to me, you and Patrick working in primary care. So of course, we're well versed to using colchicine, aren't we, in primary care for gout. And actually, many of you will be aware, colchicine is one of these medications derived from plants. It's actually found in the common garden plant, well, apparently common, I'm no gardener, the autumn crocus. Like the SGLT2 inhibitors, the florazine, of course, that SGLT2 inhibitors are based on are from the root bark of apple, aren't they, of the apple tree. So yeah, we've been using colchicine for many, many years. And in fact, I was just reading a little bit up on it. Apparently there's reports of using it as far back as 1500 BC to treat joint swelling. I think that's when Patrick perhaps started medical school.
I was going to bring up the crocus thing actually, because myself and Patrick have a little kind of ongoing thing about where we derive medication from.
Yeah. But it's a great story, isn't it? Yeah, in this kind of era, especially as you mentioned, Kevin, the horrible situation we're in with the pandemic, all these modern therapies, and then this, something that's been around for centuries, is potentially something of value in this pandemic.
Absolutely. I mean, it's essentially an anti-inflammatory, isn't it? And that's why we commonly use it for gout. And most modern rheumatology guidelines place colchicine alongside non-steroidals, joint first line for the management of gout. So it's generally well tolerated, often limited by its GI side effects, isn't it? The diarrhea predominantly, but something we're very much used to. But really over the last year, it's very much the case of old dogs, new tricks, isn't it? And it appears that we're repurposing colchicine as a cardiovascular drug. And I know, Amma, this was a particular interest of yours over the last 12 months. A couple of big trials, wasn't there, suggesting cardiovascular benefits of anti-inflammatory colchicine?
Yep, I remember us discussing that in our kind of ADA and ESC reviews, actually, wasn't it, before? Colchicine, yeah, there's been a lot of investigation of it. Because of that, you said the anti-inflammatory properties. There's a theory that it would help with kind of atherosclerosis and reducing cardiovascular impact and disease. And that was shown before with other trials with interleukin-1 products such as canakinumab. So the same thing with colchicine. So they looked at it from a cardiovascular point of view, and there are two main trials really in the last 12 to 18 months. There's ColCORONA, which basically looked at colchicine 0.5 milligrams once a day in people who had a heart attack, so post-MI, in the 30 days prior or so, and they gave them 0.5 milligrams, and they found that that dose basically reduced the primary outcome of cardiovascular death, cardiovascular MIs, strokes, and revascularization. So we had proof at that point in a good trial post-MI that colchicine worked. And then a bit later, another trial came up and said, fine, okay, Post-heart attacks, it works, but what about those with chronic heart disease who don't have an MI, who aren't having an acute event? Maybe it's a different group. Do they have benefit from colchicine? And again, this was something called LOCODO-2, because LOCODO was a small trial, LOCODO-2 was the bigger trial. And that also showed that 0.5 milligrams of colchicine had these same benefits, really. I mean, the finer points of the trials, but essentially that's what it showed. And so we've got a medication which we really use in one sitting only, really, in gout and maybe familial Mediterranean fever or something, but we don't really use anywhere else. That suddenly we thought, actually now, in those who have cardiovascular disease, it may improve outcomes. And we've noticed for the last about a year now, actually, almost, that this has been shown. And so this is the background for the ColCORONA trial, which we're talking about, that there is some evidence that it has some cardiovascular benefit and impact, and its anti-inflammatory properties may have benefit. And that's what I found really interesting even before this. And then when this came, this just adds to the enigma that is colchicine.
I was going to just say that looking at some of those trials that you mentioned, I was surprised by some of the background to those trials where patients were using colchicine for more than 6 months. And that actually wasn't uncommon. Now, for me, I've not actually used colchicine for such an extended period of time. I don't know, Patrick, whether you could bring your thoughts into this, but I've always used it during an acute flare of gout, essentially.
Yeah, and when you're titrating up the allopurinol, so yeah, that's how we do. Sometimes it goes on for a while, but not that length of time. But it's but going back to those studies, that it was really well tolerated. I mean, I think that's one of the things which came through those studies. And I know you're going to talk briefly in a minute about the actual study itself, but remember that in both those two studies, as Amar said, it was 0.5 milligrams once a day. So
yeah, certainly I've used it for several months or longer, as Patrick said, when titrating up the allopurinol, usually just once a day. And I think the BSR, British Society of Rheumatology, advocate it even up to 6 months to prevent an acute flare-up of gout whilst titrating up the allopurinol and getting that urate level down. So, but yeah, these extended periods are certainly not so commonly used, certainly in primary care. But in the ColCORONA trial, though, the treatment duration was about just 4 weeks, wasn't it? Just over 4 weeks, Amma.
The ColCORONA, yeah, I think so, yeah. It was 30 days with a kind of follow-up after, wasn't it? 30 days and a follow-up after, 30 days after. So yeah, there was about roughly that amount of time.
I suppose that's a good point to go through some of the details of the methodology of this trial. And this is something that was developed at the Montreal Institute of Cardiology. It's a multi-center trial. I think North America, South America, and Europe involved in it. And essentially about 4,500 participants were involved, and they were divided into 2 groups. So all of them had a diagnosis of COVID-19 by PCR test within the previous 24 hours. All of them were above the age of 40 and had one other risk factor for COVID complications, things such as history of diabetes, for example, or certain respiratory conditions, etc., and certain age limits as well. And they were split up into 2 groups. One group was given placebo for 30 days. The other was given colchicine for the first 3 days. For the first 3 days, they were given 0.5 milligrams twice a day. And then for the remaining 27 days of the month, they were given colchicine 0.5 milligrams once a day. And the beauty of this trial was that it was all conducted within the comfort of the patient's homes, which is, again, really quite unique and something that perhaps needs to be done during the pandemic as well. And so these patients were followed up at day 15 and day 30. And Patrick, the primary outcome was looking at the composite of hospitalization or death, wasn't it?
Yeah, within the first 30 days. Yeah.
Would you mind taking us through some of those results?
Okay, yeah, so I think, yeah, so the primary outcome, which we've just mentioned now, so that showed a 21% reduction. Now, there's been no p-values, no confidence intervals, or so with any of these results. But this is what we've got. Again, that as you mentioned, Amrit, from the Montreal Heart Institute. But probably more eye-catching were the secondary outcomes. So and that primary outcome was statistically significant, I believe. But the secondary outcomes was a 25% reduction in hospitalizations, halving of mechanical ventilation, and reducing death by nearly half, 44%. So, and that's all for something which I just double checked on the drug tariff, the January drug tariff. I'm a Yorkshireman, so I like it cheap. And by golly, it's cheap, £2.06. So there you go. And so, I mean, yeah, so for me, I think I was just blown away. It got me one of those, there's a few times when I see this data coming out, I really got excited because we've not had anything. I mean, what are we offering people at the moment? We're offering them hospital admission. We're supporting them at home increasingly. Sometimes, certainly early on in the pandemic, I think we were giving doxycycline, but there was, you know, really for more hope. And again, that drug has a bit of anti-inflammatory effects, so that was there.
It's evidence just come out saying that doxycycline has no benefit now. Doxycycline is erythromycin just the other day. So again, there you go.
And the thing there is that was, you know, that's, you know, a lot of the data we have is actually in patients who are already hospitalized. And again, what's so unique about this is before admission. So this is within 24 hours of a diagnosis. And the major crisis we have right now is how full our hospitals are. And if we can prevent a patient, obviously from developing complications, but also having to go to hospital, well, that's not only helping the patient, but also the health service as a whole, isn't it?
I know you're all going to jump me here, but this really is a game changer for us in primary care. I mean, on a serious note, it is, you know, for exactly the reasons Amrit said, but that's what appeals to me. I mean, the dexamethasone, of course, has some compelling data, but that's very much for hospitalized, ventilated patients, isn't it? Remdesivir as well, hospitalized patients. And then hydroxychloroquine turned out to be a bit of a damp squib in the end as well. And then good old vitamin D, the elixir of life, postulated by many, of course. Association does not mean causality, as we all know. So this is actually a real positive step forward. And what again really appeals is the simple dosing regimen, which is something we're very used to doing in primary care. BD for 3 days, once daily for 27 days. And I correct me if I'm wrong, but I think I read a figure somewhere of a number needed to treat of 60 to prevent one COVID-19 related complication with, as Patrick has already told us, a drug that costs just over £2. So a Yorkshireman and a Scot.
And how many people have COVID-19 at the moment per day in the UK testing positive? So yeah.
The one thing that gets me, and you guys are much more experienced at kind of reviewing these press releases and being hot on the heels of it and talking about it on Twitter, but the one thing that frustrates me is the lack of information. And, you know, yes, I'm quite excited by this, but as you mentioned, Patrick, you know, lacking in p-values, not really, you know, and that's to follow, isn't it? From my understanding that this has been accepted by a journal and that will all follow in due course. So until then, I'm kind of holding back my enthusiasm just a little bit, but in anticipation of that.
I mean, I think that's eminently sensible, but it does beg, I suppose, the $1 million question. You know, you're sat in clinic tomorrow, you get a phone call from a patient who has PCR positive, over the age of 40, had a temperature of above 38.4, which I believe was one of the criteria. So they qualify from it. What do? Do you talk about this study? Or even, let's make it easier for you. What happens if the patient says, I read in the Daily Mail that there's a gout drug now which might work? What would you guys do in that sort of scenario?
Well, I've got to say that the downsides to me are minimal. I mean, I always use the analogy, would I give it to my old man? My old man is over 75. He has type 2 diabetes, you know, albeit well controlled, and he's Asian. He's born and bred in Sri Lanka. So he's at high risk of adverse COVID-19 outcomes. And I think if he got it, I would suggest he takes it. His renal function's fine from his last diabetes review. And, you know, apart from the diarrhea we mentioned, the GI side effects, it's generally well tolerated in a regimen that we're used to using in primary care. So absolutely, we need to follow the evidence. We need to see the detail. But if that happened to my dad tomorrow, I'd be tempted to say, you know, in my clinic, come in and go for it.
I mean, the pedantic or the kind of the the nerdy aspect of me saying, well, you touch on an interesting subject there if you say your father or so, because again, ethnicity in this setting, we know where the population was European, North American, and South American, and South African, I think it was that side. So again, it'd be interesting to know what the breakdowns where the data comes in of the populations. You know, as a secondary care physician, obviously it's slightly different on my side. They are looking at Colchicine as part of the recovery trial, and I have recruited people with the Colchicine arm, so we will get inpatient data as well on Colchicine, and that'll be really interesting as well if we match both. But I agree. I mean, from my perspective, from the secondary care as well, so I'd say, yeah, you know, the evidence behind it. So I'm hoping the evidence behind it, but the numbers coming out of it are very, very good from the sounds of things. And yeah, in terms of risks benefits, I think the benefits of it would outweigh those risks at that point, which is just mainly GI disturbances. So yeah, I'm behind this. Obviously, you know, I'm going to wait for the main data, wait to review it. Not going to do anything yet. But yeah, I'm looking forward to this data, and hopefully it'll come out in the next week or two.
It's a different situation if the patient presents that to you as opposed to you offering it as an option.
Mm-hmm.
So I agree pretty much with what you guys are saying, that if a patient comes to me, yes, I think it'd be, first of all, I'd be quite excited by the fact that a patient is bringing that to me and to have that discussion. But yeah, I think after, you know, the frank discussion of the risk versus benefit, then yeah, it's certainly something to consider.
Remind me again, Amrit, do we qualify for this medication?
Well, you make an interesting point, Emma, because we were discussing between the four of us, you know, if we, you know, had COVID-19, would we be willing to take colchicine? And Amar and I, obviously, based on the trial data, would be excluded from doing that because of our youthfulness and whatnot. Just under 40, but under 40. But yeah, I mean, Patrick, what about yourself? I mean, would you be comfortable using this in patients?
For myself, I think if I was to, you know, be diagnosed with COVID, I think I would qualify, as you nicely, politely pointed out. But I think certainly if a patient raised it, I would be pragmatic. I think there are harms. I would want to see the data, but I'm reassured from some of that data, which, you know, the ColCORONA study and the LOCO-DOCO 2, you know, that was really well tolerated there. So I think that in the press release, they said diarrhea was more common. Obviously, diarrhea can be a problem for some patients with COVID. So maybe it's not for everybody, and it's not going to be for those with severe renal problems or the very frail. So not everybody. But I think, yeah, I think if someone raised it, I would do that. If I thought they're at high risk, and then we're left with that difficult question, you know, what else are we offering them? And I think at the moment there isn't anything else other than just keeping our fingers crossed. And I think what we do need is that paper, because that's going to make our life a lot easier, because then we can have a proper, fully informed, balanced conversation. But at the moment, you know, my gut feeling would be, if I was presented with that, yeah. It does raise the question, because at the moment, I don't know about you in primary care, but, you know, 111 are mopping up most of these patients. So we're just getting the results through, and there's only a minority of patients who are actually seeking advice. They're self-managing, or some of them are going, sadly, straight to hospital. So we look after those in-betweeners, perhaps. But as we said, those in-betweeners are exactly the sorts of people I think this study was for.
And it does pose the question with kind of the previous data with ischemic heart disease, or with people with chronic heart disease, or who've had an MI recently, you know, why aren't we starting with them as well? I mean, that's another topic for another day. But again, in that group as well, who may have COVID-19 as well, then that's a double reason to kind of look at it really in that way, because, you know, we've got good evidence from that side of things, from what I mentioned. So interesting.
Definitely. So I know this is a breaking news episode, so it's shorter than normal, but is there anything that anyone wants to kind of add to the discussion before we round up?
Well, just watch the space for the paper, as Patrick said. I'm sure we'll revisit it in a future episode of our GoggleDocs videos. So yeah, watch this space. The devil, as always, is in the detail, but very, very promising so far.
And as a bit of a guess to where it'll be, the last two papers Amar introduced were both published in the New England Journal. So I suspect that's where this one will be.
That's
there we go. There we go. So thanks, guys. Really interesting trial to discuss, and you know, during a time when, as Patrick, you were saying, very few options, unfortunately, still in the active management of COVID in the community. So great to discuss that. Hopefully we'll have some more details as well soon, and perhaps that's something that we can kind of go through in a little bit more detail in one of our following podcasts. But that's all from us today. If you like what you saw today, please do have a look at our other videos. We're going to try and release a video a week or so. And obviously, if you like what you see, please do subscribe as well. That would be great. And do follow us on Twitter. This is the part where, you know, the running joke, I'm going to hand over to Kevin to talk to you about our, well, first of all, we've got a GoggleDocs Twitter account and then our personal accounts as well. So the GoggleDocs one first, Kevin?
I'll probably ask you.
Amar.
Yeah, so it's at GoggleDocs, essentially. Very simple. And, you know, my one is at Amarput, AMARPUT, if you're interested.
My one's at Dr. Kevin Fernando, DrKevinFernando.
And I'm Dr. again, Dr. Patrick Holmes.
And I've had more activity on my Twitter profile today, or Twitter account today, than probably in the last 2 years since the launch of GoggleDocs today. But mine is Dr_Amrit Lambert.
And if you follow him, the more people who follow him, the more likely he is to come on Twitter. So it's another incentive.
That's great. Thanks a lot, guys. Good to see you all, and see you all soon. Take care.
Bye-bye.
See you next time.
Bye.